I'd like to welcome everybody to our OCAD multidisciplinary lecture with a focus on pediatric rheumatology today. We are fortunate to have Dr. Julie Fuller, who is a graduate of Texas A&M Health Science Center College of Medicine. She completed her general pediatric residency and pediatric rheumatology fellowship at the University of Texas Southwestern Medical Center in Dallas. While she has a clinical and research interest in juvenile dermatomyositis, she evaluates and treats all pediatric rheumatology conditions, including vasculitis, scleroderma, SLE, juvenile arthritis, and recurrent fever syndromes. She was included in D magazines. Is that Dallas? I don't know. Dallas Magazine's Best Pediatric Specialists list in both 2020 and 2021. And she is a pediatric rheumatologist in the Department of Pediatrics at UT Southwestern Medical Center and practices at Texas Scottish Rite Hospital for Children and Children's Health, Dallas and Plano, Texas. For everybody joining us now, please mute your mics. At the end of the lecture, Dr. Fuller will be happy to field questions. Just enter your questions in the chat. Thank you. Go ahead, Dr. Fuller.
Okay. Well, thank you for having me. I'm pleased to be able to talk with you all about juvenile arthritis, and hopefully this is a little bit targeted for the radiologist. I have no disclosures. Here's our learning objectives for this afternoon. We're going to talk about the different types of JIA and their typical presentations. And then we'll also discuss which lab work is appropriate in evaluating these patients. And we'll also talk about basic treatments used for juvenile arthritis patients. So as I was told by Hamza Alizai, who invited me to give this lecture, this was a purely clinical talk. And so I have 0 x-rays or radiology images in this lecture, as you guys already know all those findings and want to know more about the clinical presentations. So starting from the beginning, we're going to talk about what is exactly arthritis. So obviously breaking down the root word from the Greek, it stands for joint inflammation, and this is not focused on joint pain. Joint pain, as you know, is a very large differential with variety of causes, but inflammatory arthritis is the focus of this talk. So what causes joint swelling? There are a variety of causes, and every time a patient comes into our clinic, it's really our job to figure out, is there joint swelling or just joint pain? And if there is swelling present, which of these categories does it fall into? Because of course, things like Crohn's and ulcerative colitis can present with joint swelling and then initially go on to have GI involvement. We get about 1 or 2 cases of leukemia per year that present with knee swelling. We certainly see post-infectious, like post-streptococcal reactive arthritis and infectious arthritis, such as septic joints. And of course, trauma is an obvious cause of joint swelling, but typically does not get referred to rheumatology. So the focus of our talk today is idiopathic joint swelling or juvenile arthritis. So what exactly is juvenile idiopathic arthritis? This is a newer term for some of you that may have been in practice for a bit longer. You may be more familiar with the older, more dated terminology called juvenile rheumatoid arthritis, but this was actually renamed in 1997 by an international rheumatology group that wanted a more descriptive name because these patients typically don't have positive rheumatoid factor and they don't all act like adult rheumatoid arthritis. So therefore they renamed it juvenile idiopathic arthritis to indicate that these patients don't necessarily have rheumatoid factor positivity and their swelling is idiopathic in nature. But the other thing that's important to realize is that this is a chronic condition that does have periods of flare and remission. Many times people think about juvenile arthritis as something that kids will, quote, outgrow, but this is not something that necessarily is outgrown and may actually go into adulthood. And the data suggests about 10 years out, 50% of patients will still have active inflammation from onset. So I put this slide in there to also show what it isn't, because many people do send referrals to our clinic after they get some x-rays that show maybe some changes in facet joints or back, imaging that looks a little abnormal at a primary care physician, and they want the patient screened for osteoarthritis, but that's actually not a recognized subtype of arthritis according to the ILAR criteria or International League Against Rheumatism that I'm going to be discussing with you today. We also don't seek out in this pediatric population. There's just a couple of very, very rare occasions. I've seen it once in a 17-year-old, but it's usually in the setting of an underlying metabolic abnormality or renal failure where they can't really process uric acid properly. And that's also not a recognized subtype of childhood arthritis. And then I put an incomplete line through the rheumatoid arthritis circle because, as you'll see later in my presentation, 3 to 5% of our childhood arthritis patients can have a subtype that's very similar to adult rheumatoid arthritis. So here's a slide with the diagnostic criteria for juvenile arthritis. And as you can see, the criteria is very short. You really just have to be under age 16, and that's really just for kind of an academic cutoff. If you're over 16, you just fall into an adult category. And you have to have joint swelling in the same joint for 6 weeks or longer. And you have to exclude other causes, and that's really it. So what do we know that causes juvenile idiopathic arthritis? And the answer for this is we don't know. There is no known cause, and we feel it's likely multifactorial with some genetic predisposition and then also probably some second hit or environmental exposure. We know most of our patients don't have any other family members that have a history of juvenile arthritis, although we do have a few sibling pairs and a few parent-child pairs in our practice, and that has been reported. We do know that autoimmune diseases tend to cluster in families. So while there may not be another family member with specifically JIA, there may be other conditions like thyroid disease, celiac, MS, type 1 diabetes, for example, or a grandparent with rheumatoid arthritis or someone with lupus. So those can cluster together. And we do know that there is some increased risk of JIA in certain patients with chromosomal disorders, such as trisomy 21, Turner syndrome, and DiGeorge syndrome. They have looked at a variety of environmental exposures. For example, certain childhood illnesses. We do know that there is an incidence of reactive arthritis following strep infection, but that's not also a chronic arthritis. And we have not been able to identify any specific viral illnesses or vaccinations. And again, that points away from other household members that have similar environmental exposures tend to not have the same disease process. So the best we know is that you probably have a genetic disposition, and maybe the right virus at the right time brings on the condition, as many childhood patients do have history of some type of viral illness prior to onset. Why do we even care about juvenile arthritis? Most people don't know, but childhood arthritis is actually the most common cause of acquired disability in children. So aside from birth defects, this is what disables kids. And there's about 300,000 children currently living in the United States with arthritis, and that's a prevalence of about 1 in every 1,000 kids. Sadly, there's only about 420 of me, board certified pediatric rheumatologists as of 2020. And this is a little bit older data. I couldn't find a newer map, but at the time, 4 years ago, 9 states still had no pediatric rheumatologists whatsoever. And as you can see, there's states there with 0 pediatric rheumatologists, meaning many of these children are actually cared for by an adult rheumatologist or a primary care physician, and only about 25% of pediatric patients actually see a pediatric rheumatologist. The average length that a patient will travel to see a pediatric rheumatologist is about 60 miles. So we're lucky. I'm here in Dallas. It says 24 in Texas. We have 4 cities, Dallas, Fort Worth, Austin, and Houston, that do provide pediatric rheumatology care. But for a while, there was no pediatric rheumatologist in the states surrounding us. So we were absorbing a lot of patients per attending. So I also explained to parents that have never heard of childhood arthritis, and they ask me why they've never heard of this condition if it's that common, but obviously we don't get a lot of media attention, and our patients are generally cared for as an outpatient. But I tell them that usually there's about one child per school, depending on the size of the school they attend. And this is about the same frequency as kids with insulin-dependent diabetes, Crohn's disease, or ulcerative colitis. And actually, it's 5 times as common as the most common type of pediatric cancer, ALL. So here's a breakdown of the types of chronic childhood arthritis that we're going to be discussing today. These are the 7 recognized subtypes of childhood arthritis, and we're going to go through these with some cases so that you can better understand what we see and what we're looking for when these patients present to our clinic. So here's our first case, and it starts with a 2-year-old blonde-haired, blue-eyed girl who's very fussy and irritable first thing in the morning or whenever she gets up from a nap. She seems like she wants to be carried, or she'll walk with a limp for a little while the first hour or so after she's awake. But then later in the day, she seems completely fine, active, playful, no problems. And then her mom recalls that maybe she fell while playing on the playground, but she's otherwise completely well with no fevers or rashes. And I've highlighted the key points in this case because her age and probably having Northern European genes with blonde hair and blue eyes is a key point in this case. And she's also describing morning stiffness with the fussiness and irritability, wanting to be carried and limping for the first hour. And she's otherwise completely well. And this is actually a patient from our clinic who is around that age that presented. And as you can see, she stands with her right knee slightly flexed, and there's just some subtle fullness where you can't see the borders of her patella very well. And this is how subtle it can be and why it's often missed by primary care physicians or parents, because toddlers have chubby joints and it's really sometimes difficult to notice. But this is a very classic presentation of oligoarticular JIA. And here's some additional pictures with right knee swelling, and then this is left ankle involvement that you can see. But this classically presents in the very young child between age 1 and 4, and that's actually the most common age in our clinic. And 75% of these patients are actually female and mostly of Northern European descent. So lots of little cute blonde hair or redhead kids in our clinic. They all have a history of morning stiffness, whether the parents have realized that or not. And of course, because they're all toddlers, they all have a history of trauma, but really the trauma history is a red herring because all these kids fall, they play hard, they go outside, but that's not what's going on here. And they're otherwise completely well. They don't have other systemic symptoms like fevers or rashes. So by definition, oligoarticular JIA means they have swelling in under 5 joints, so between 1 and 4 joints. And about 50% of the time, it's typically only a single joint, with the most common areas affected being a knee or an ankle. And sometimes it can be very subtle. Usually when there is swelling, they do lose range of motion, but because kids are so hypermobile at this age and have so much range of motion, it may just be loss of hyperextension in the knee on exam. You may also see, or the parent may describe that they're walking out-toed on one side, or they're developing overpronation of their ankle. And that can occur if there's swelling in the talonavicular or subtalar involvement. And then usually with abnormal weight bearing, these kids do develop some muscle atrophy fairly quickly, where they may have one calf that looks smaller than the other, or this picture on the right shows some bilateral knee swelling and thigh muscle atrophy. These patients are sometimes missed because lab work is generally normal. So if parents present to a primary care office and have CBC, ESR, CRP drawn, they're going to look great. Sometimes they get picked up because about 80% of these kids do have a positive ANA, and we know a lot of primary care doctors like to draw that with any joint concerns. And when it returns positive, they will forward those on to rheumatology evaluation. You may see sometimes on our notes or charts that we have put some additional subtypes down to better clarify their actual disease course. And so there are 2 further subtypes where we may note their persistent oligoarthritis, and that means that they continue to have between 1 and 4 joints. Or you may see the term extended oligoarthritis, which means after their initial presentation, after 6 months, they do go on to develop really more of a polyarticular course with greater than 5 joints. And that really just helps us think about the patient and their long-term prognosis and what medications may be best for them, because the more joints they have, or the more persistent their arthritis is, the more likely they'll have chronic or relapsing illness. Oligoarticular arthritis is the most common subtype of JIA in the United States, probably around 50 to 60%, but does vary in other parts of the world. So depending on where you are, it may be about 30% of childhood arthritis, with more patients having polyarticular presentation. These patients are at risk for leg length discrepancy if undertreated, because what happens with the inflammation is there's increased blood flow to the swollen joint, and that brings actually extra growth factors. And so these patients will frequently have some bony hypertrophy around the joint that's affected, such as the knee or ankle. And that can become a real issue if it's a weight-bearing joint and they're little like this between age 1 and 4, because they have a lot of linear growth they still have to go through. So you do need to be very careful of this and aggressively treat kids, even if it's a single joint. I've had some patients that were told at outside places just to wait and that the child may outgrow this, but they'll have a very significant leg length discrepancy and have other weight-bearing issues or hip problems later from that. However, oligoarthritis is generally the best overall prognosis, and many of these patients can be treated with just NSAIDs or steroid joint injections and actually have a long-term remission. So I added this slide as a caution because sometimes we get called by the community doctors who have a patient that they want to be seen urgently, but they're describing to me a hot red joint or difficulty weight bearing and very acute in onset. These are all obviously signs of infected joints. We don't want patients that are unable to bear weight or having fevers waiting on an outpatient rheumatology appointment. They need to be seen in the emergency department and have appropriate joint aspiration and lab work drawn. So any child that's ill appearing needs to be seen urgently for infectious causes. And of course, other things can present with single joint involvement, like I alluded to, if they're having low-grade fevers, any history of weight loss or bone pain, or more inflammation than we would expect on lab work is also a very big red flag for this, and needs to have appropriate workup for infection or things like malignancy, IBD, or other inflammatory conditions like chronic recurrent multifocal osteomyelitis, or other rheumatic diseases like vasculitis, etc. The other thing to be cautioned with a child with oligoarticular involvement and a younger kid is when it's hip involvement, because hip involvement in the younger age group as an isolated joint finding is very unusual. So we're going to go on to our next case, and this time we have a 12-year-old Hispanic female who has a 3-month history of morning stiffness and swelling in her fingers that she's noted is worse on mornings that are cool and damp. She gets to school and has trouble holding her pencil for her writing in the morning, and sometimes has difficulties with activities of daily living like buttoning her clothing, opening her drinks. But she was told by her primary care physician that her labs were negative for arthritis. And here are the key features. This is a little bit older child, but still describing very clear morning stiffness and finger swelling. And she's noting worsening symptoms with weather changes. She's also having difficulties with activities of daily living. And this is a little bit blurry when it's blown up, but this is an image that I borrowed from the American College of Rheumatology, as they have an image bank with a lot of helpful clinical photos. But you can clearly see the polyarticular process that's affecting this patient, worse in the PIP joints, but also probably some in the MCP joints. And you can see spares the DIP joints. So this is a good illustration of seronegative polyarticular presentation. And this actually has a bimodal age distribution. So it initially can present again in those toddler years between age 1 and 4, but can also occur in older children around puberty. By definition, as we discussed, polyarthritis means 5 or more joints. And typically these kids present with a large number of joints. Multiple finger joints involved, wrists, knees, and ankles are also very common locations. And it's not unusual for them to have 30+ joints involved at presentation. The picture on the top is also illustrating a patient with TMJ involvement and resultant micronathia, which we'll talk about a little bit more. They can also have cervical spine involvement, which is very common with this type of presentation. And as I mentioned, spares the DIP joints classically. This represents about 15 to 20% of juvenile arthritis patients in the United States. So key features, these patients do typically have symmetrical joint involvement. And as I mentioned, may involve the TMJ and C-spine. And I think I have some additional pictures here of an actual patient from our clinic that had TMJ involvement and developed micrognathia, because what happens with this, if they develop arthritis in the TMJ, usually under 8 years of age, there's underdevelopment of the mandible. And this leads to micrognathia and a lot of bite issues with their dental work. They're going to require really a TMJ replacement to correct this and bring the entire jaw forward into better alignment. And you can see this is actually the same patient that had the procedure completed around age 16, because they typically want to wait until they're skeletally mature and quit growing. And you can see her scar there, but they also have just a drastic cosmetic improvement from this as well. These patients are oftentimes missed at lab screening by primary care physicians because their labs are seronegative. And by definition, that means arthritis markers like an ANA, a rheumatoid factor, a CCP antibody, or HLA-B27 antigen are negative. These patients may have mild to moderate inflammation on lab work, but oftentimes their labs are surprisingly normal, even with 30 swollen joints. And only about 25% of these patients will have a long-term remission. So definitely more of them will require long-term medication. So here's our next case. And this is a 17-year-old Hispanic female who has 3 to 4 month history of joint pain, widespread in her neck, jaw, shoulders, elbows, wrists, fingers, hips, and knees. She doesn't even want to shake your hand when you enter the exam room, and she has a large degree of joint swelling you can see from across the room. She has limited range of motion of her neck and difficulty opening her mouth. And here are the key features of this case, because you can note she's a little bit an older teen, has obvious widespread involvement, really has more pain with even touching her joints, arranging her joints, and is very swollen and has already several areas of decreased range of motion. And this is a representative case of seropositive polyarthritis. So as I alluded to, these patients tend to be a bit older, usually kind of more in the 15 to 18 year range. And this is an aggressive diffuse arthritis that does include the DIP joints, but tends to spare the lower axial skeleton. They can really have pretty much anywhere else involved, including their C-spine and jaws we had discussed with some of the other cases. And this type of arthritis causes more pain than the other types. We actually have some studies to show that if the chief complaint to rheumatology clinic is joint pain, you're already 95% certain that they probably do not have arthritis. When the chief complaint is swelling, they probably do have arthritis. So that's actually been in a published study that's very interesting. But this type of arthritis may present with joint pain. It also leads to early bony deformities and bony erosions on imaging, as you're aware of. And this is the name basically for the equivalent of what's known in adult rheumatology as rheumatoid arthritis. This represents only about 3 to 5% of childhood arthritis patients. And I included a couple pictures of some of the early joint deformities. The picture on the toes is demonstrating some hammer toes that we can see occur very early in the course. And then the picture of the hands, I was trying to get a picture, it's not fantastic, of some ulnar deviation. And that patient clearly has, very large thumb IP joint swelling, and maybe some early boutonniere deformities of those 5th PIP joints. So these patients do often get caught on lab screening because these patients, as we just defined as seropositive, have a positive rheumatoid factor and a CCP antibody, which stands for cyclic citrulline peptide, which is known as an adult RA marker. And so a patient that goes to a primary care office and their pediatrician or family doctor draws some type of arthritis panel often will include these antibodies, but even basic labs will oftentimes show very elevated ESR and CRP levels and signs of systemic inflammation with anemia, elevated white count, and platelets. You have to be very careful though, when you have a patient that has positive antibodies, they also need to be screened for systemic lupus erythematosus, because polyarthritis is one of the presenting clinical features of that autoimmune condition as well. So here in Texas, where we have a very high Hispanic population, we've really made it pretty much a policy that anyone 8 or above presenting with polyarthritis, if we're getting labs, they need to have full lupus antibody workup as well. And these patients may also have some low-grade fever and weight loss, although it's not typically acute in presentation and very low-grade in nature. And here again are some additional clinical findings that you will see with the boutonniere deformities as demonstrated in these hand photographs. And the one on the far left is actually demonstrating a swan neck deformity. So instead of it having a contracture at the PIP joint, it kind of tends to be subluxed and then curved at the end. Seropositive polyarthritis, as mentioned, is very aggressive. And with early bony erosions, these patients are often recommended to start combination therapy at diagnosis. So we don't typically wait for a trial of NSAIDs in any patient that has over 3 swollen joints. They're going to need some sort of DMARD or disease modifying antirheumatic drug. And with seropositive patients or early bony erosions on imaging, we tend to encourage them to start combination therapy with a non-biologic and biologic DMARD at the same time. So for example, methotrexate plus a biologic medication at diagnosis. These patients will probably require long-term medication. They only have about a 2% chance of long-term remission off medication. They may do well for a year or 2 off, but they probably won't be able to stay off throughout their life. And this means most certainly their disease will follow them through their adult years. Here's our next case, and this time it's a 3-year-old white male with a 2-month history of morning limp and right knee swelling. But now the family's noted his left 4th toe is very red and swollen, and they tell you it looks like a sausage. His primary care doctor thought it was probably from new shoes rubbing and then gave him a course of antibiotic for presumed cellulitis, but it's not really tender and there's not been any fever. And then later questioning shows family history with dad with psoriasis. And here are the key features in this case. It's a smaller child with subacute presentation of what sounds like some knee arthritis with morning stiffness, but now presenting with a dactylitis that's not particularly tender and really doesn't fit the clinical picture for a cellulitis. And then the other feature is obviously dad or 1st-degree relative having psoriasis. And here's another picture from our image bank of a toddler with dactylitis. And you can obviously see the chubby fat toe. You really don't see the swelling isolated to the toe joint. It's really involving the entire toe. And that's representing really a tenosynovitis, really a flexor tenosynovitis down the entire length of the digit. And these patients don't have obvious pain or any other signs or symptoms of dactylitis, such as associated with sickle cell disease. So this is psoriatic juvenile arthritis. And again, this subtype of arthritis has a bimodal age distribution. So they can present as a toddler, typically between age 2 and 4, and then also kind of in the pre-pubertal years between age 9 and 11. And these patients for definitive diagnosis are really supposed to have both psoriasis and arthritis, but we rarely see that in pediatrics. Most of the time they do not have active skin disease, and they may or may not go on to develop active skin disease because we're going to put them on medications for their arthritis that are going to mask some of that. So most of the time in our clinic, we're using the diagnostic criteria of arthritis and 2 of the following, which includes nail pitting or a family history of psoriasis in a 1st-degree relative or obvious dactylitis. And sometimes you'll see on our charts, we'll call them probable psoriatic arthritis because they may not get 2 of the diagnostic criteria, but they present with dactylitis and arthritis in another joint that's very suspicious for this subtype. And there's again another picture with some dactylitis. Here's an image I included just to show you the nail pitting. If you look at a lot of fingernails on a regular basis, like we do in our clinic, it's frequent to find some nail pits, but they really need to have like 20 or 30 nail pits to really be considered a psoriasis feature. And so these are very classic. There are some other features of psoriasis affecting the nail, including some horizontal nail ridging. But it has to be horizontal because vertical nail ridging is very common. So these patients may have arthritis markers, particularly the positive ANA test or HLA-B27 antigen, but they don't have to. And as I alluded to, half of them will present with arthritis first. I would say in my clinical practice is actually probably higher than that, but that's what's reported in the literature. These patients have a classic pattern of asymmetric small and large joint involvement. So by what I mean with that is they may have one or two toes, a wrist on one side, and a knee on the other side. So it's not the symmetric polyarthritis that we talked about previously. And frequently these patients are oligo subtype at presentation. So they have under 5 joints, but then you follow them for a little bit and they really develop more of a polyarticular course if left untreated. This subtype of arthritis can also cause axial involvement with sacroiliitis, and they can also have some overlap with another subtype of arthritis that presents with enthesitis. And this represents about 5 to 10% of juvenile arthritis, according to this literature. Here's our next case. A 13-year-old white male with 10-week history of right ankle swelling. He thought was just a basketball injury, but now his left heel is very swollen, it's a little bit red, it's warm to touch, and he's having difficulty bearing weight. He can bear weight, which is the key feature here, but it just hurts. His left knee is also swelling, and again, there have been no fevers. So we have kind of a preteen with history of one joint swelling, and now we have some heel involvement, but no fevers. And here's a picture showing what we're trying to show as enthesitis. And this is someone with some Achilles enthesitis, but also probably some ankle effusion, if we're going to be honest here. And this is a representative case of enthesitis-related arthritis. So this is usually a patient around puberty and also usually a male patient between age 9 and 12. We tend to think about this anytime it's a boy over age 6. And by definition, they have to have a large joint arthritis and findings of enthesitis, but they can also have sacroiliitis, or they can have primarily lower joint extremity involvement. So hips, knees, and ankles are most common. You can have shoulder involvement, but finger involvement, TMJ involvement would be very unusual. This is a subtype where you can see isolated hip involvement, but it tends to be in an older boy. So not the toddlers that we talked about. That would be a red flag needing other workup. And about 80% of these patients are HLA-B27 antigen positive. Although that's according to adult literature, there has been some recent publications within the last year suggesting that HLA-B27 positivity in childhood may be a lot lower than this, probably around 40 or 50%. This subtype is a little bit confusing because it goes by several different names. In the adult world, they would call this ankylosing spondylitis, but sometimes we call it juvenile ankylosing spondylitis if there's involvement of their low back area. Sometimes we'll just call them ERA, sometimes we'll call them juvenile spondyloarthropathy, sometimes they'll be called HLA-B27 positive sacroiliitis. So it's very confusing as far as the nomenclature, depending on what institution you're at and how they practice, but the recognized ILAR criteria subtype is under enthesitis-related arthritis. And I'll usually explain to these patients, no matter how they present, there is some low back risk of low back involvement, particularly with time, because many of these patients will present with peripheral joint involvement involving a knee or ankle or hip. And then after about 5 to 10 years, they're at higher risk of developing sacroiliitis. And this represents probably between 5 and 15% of our juvenile arthritis patients. Here is a picture just to show you, I know you're very familiar with the areas of or the entheses throughout the body, because you guys image these on a regular basis. This is from an adult paper. This study was looking at what are the most common sites of enthesitis in adult patients, which for them included actually shoulder and elbow. But in the pediatric literature, it's typically around the knee is the most common location, the patella, or around the Achilles insertion sites, particularly on the heel. And I included a slide here about sacroiliitis because this is a joint that we always ask for your help imaging. Obviously, this is a deep joint. We suspect sacroiliitis in a patient that may be complaining with buttock pain, and it can be low back or it can be over the buttock and extending down the back of the thigh. But it's also very common for SI pain to present with anterior groin pain. And because these are often teenage boys who are active in sports, these can go undiagnosed for some period of time because oftentimes they'll see an athletic trainer, or primary care doctor, or sports medicine doctor that may tell them, you just have a strain, you need to do more stretching, but the pain never improves with stretching or with rest, and it can progress and radiate. And they can also classically tell you a lot of times they have pain or stiffness in the morning, particularly difficulty bending over to put on socks or shoes is a common complaint. And they'll tell you they can't sit crisscross, although older kids don't sit that way at school much. And when you examine them, you may find pain on direct palpation of their SI joints, but you can also do this maneuver called a Faber test, which stands for flexion at the hip, abduction, and external rotation. And when you apply pressure to the contralateral anterior hip, and the opposite knee, they'll jump off the exam table and let you know that's extremely painful for them. In adult patients, there's a lot of other maneuvers that are used to assess for ankylosing spondylitis or back involvement, but these are really all late findings and they're not really validated in children because they all look at measuring different amounts of ankylosing, and these patients don't have ankylosing, they have active inflammation. It's not for many years of untreated arthritis that they're going to be at risk for developing these bony bridges. And so all of these other measurements, like a modified Schober's test, or you can do one where they're standing and they're bending forward and you measure the distance between their fingertips and the floor, those are really poorly correlating with our pediatric patients because they're going to maintain a lot of that flexibility for some years. When I have a patient with sacroiliitis, I do counsel them that there is also a high recurrence rate with this. So these patients, these boys that are on medications to treat their arthritis, we encourage them to stay on those medications for long term. There is quite high of a recurrence rate, particularly if they have sacroiliitis. And here is probably our I wouldn't say our favorite, but we enjoy systemic arthritis cases here in Dallas because we have some particular research interests in this, but we're going to go through this case of systemic arthritis. I've already given it away for you. But this is an 8-year-old girl, Hispanic girl, who's in the hospital with 3 weeks of daily fevers that are spiking in nature, hitting 104 every afternoon, accompanied by a pink splotchy rash that's flat, but she says it's mildly itchy. And she's overall very ill appearing, complaining of multiple arthralgias and myalgias, and her labs are very abnormal with elevated white blood cell count of 25,000 with left shift, hemoglobin 7.8, platelets of 640, and her SED rate and CRP are both very elevated, SED rate 94, CRP 18 milligrams per deciliter. She's been admitted to the hospital, but seems to not be responding to IV antibiotics. And here are the classic features for this case, which include spiking fever, typically in the afternoons, and a flat evanescent rash that typically comes with fever spikes and can be itchy. She's ill appearing, has a lot of arthralgias, myalgias, and these labs are very inflamed. Here are some examples of the rashes seen with systemic juvenile arthritis. And you can see they can be anywhere on the body, but interestingly, they come and go with the fevers. So while you may have rashes in these locations, a few hours later, they may completely clear when the fever's down, and then they may recur later that day in different locations. And as I alluded to, this is a case of systemic onset juvenile arthritis. So this type of arthritis is very different from the other types of arthritis. And while it does cause arthritis, these patients have a lot more inflammation, and it's the only subtype of arthritis that's really truly associated with fever and rash, unless you're counting psoriasis. These patients can be any age or gender, all even. And as I mentioned, they are very inflamed. And we oftentimes will check a ferritin level because that correlates nicely as an acute phase reactant and can help separate, is this infection versus systemic arthritis. An infection, a ferritin level commonly will run around 500 to 1,000. These patients can have ferritin levels over 60,000, very, very high. This type of arthritis can also present with pericarditis and serositis. So pleural effusion and pericardial effusion are very common. And we'll talk about the diagnostic criteria on the next slide. Unfortunately, this is a very severe illness and can lead to macrophage activation syndrome, which you may or may not be very familiar with, but this is a very uncontrolled inflammatory response that involves activated T cells and macrophages that basically go into the tissues and become histiocytes, where they phagocytose normal blood elements, and that's what causes these cytopenias in macrophage activation syndrome. So initially they'll present with very high white count and platelet count, and then with MAS, they have cytopenias. And they can oftentimes have a multi-organ failure and present with a DIC-like picture with very high LFTs and D-dimers, and often in the ICU, and this carries about a 30% mortality risk. So here's the criteria for systemic arthritis, and it really requires 2 weeks of fever, and the fever has to be over 39 degrees Celsius. It's typically quotidian or double quotidian in nature, so most common they spike in the afternoon, but they may have a second spike in the early morning around 4 a.m. They have to have fever at least 3 days of the week, and arthritis is part of the old criteria, although this is probably going to be updated and changed. They used to require 6 weeks duration of arthritis, but now we know arthritis is actually kind of a late stage finding of this, and these patients are so ill, if you wait for them to develop arthritis, or certainly have arthritis for 6 weeks, they have a very high risk of MAS. So as alluded to, they present with an evanescent erythematous rash that classically comes with a fever. They can have some dermatographism. It can be sometimes urticarial looking, but most of the time it's flat. And about a third of the kids will tell you it's a little bit itchy, but not excessively. They also have hepatomegaly or splenomegaly and lymphadenopathy. Or they have to have serositis, as mentioned. And this is around 10% of our juvenile arthritis patients. And if you're familiar with adult patients, this is thought to be on the same spectrum as adult onset Still's disease, but the childhood presentation. This subtype of arthritis really ultimately may get moved to a different classification altogether. Because there's so much inflammation, it's likely this may be considered an autoinflammatory disease and not really under the subheading of juvenile arthritis in the near future. And then just like everything else, there's a category for undifferentiated, which means that the arthritis doesn't meet a diagnostic criteria for any of the other types. So I wanted to mention briefly a few additional things, and I wanted to talk about uveitis quickly because many of our patients with childhood arthritis develop uveitis, and we're not 100% sure why that occurs, but uveitis is inflammatory cells, white blood cells, mostly neutrophils in the anterior chamber of the eye. And with pediatric arthritis, it's usually an anterior uveitis. You can get uveitis anywhere, but in the posterior chamber, but that's not typical for JIA. And because our patients are often little, these findings are asymptomatic often until late stage. So they don't affect their vision until it's very, very close to complete vision loss. So our kids have to go for routine ophthalmology evaluations because it really takes some practice to find this on a slit lamp exam. So they really need to be seen by a skilled ophthalmologist and not just a routine vision center or school eye test. But without treatment, this can certainly lead to blindness, and it needs urgent therapy. And here are some pictures just to show you the findings, which you may be familiar with, but the top left is obviously a very severe inflamed eye with a hypopyon. You can kind of see the white snow that settled at the bottom of the snow globe, if you will. And those are all the inflammatory cells in the anterior chamber. And then you can see the pupil itself is very irregular. And that's because there's so much inflammation in the iris and ciliary body. What can happen is there can be some adhesions that form, and then you have distortion of the iris. And then the middle picture is a picture of band keratopathy, which is unfortunately a late stage finding of uveitis and childhood arthritis. And that means there's been inflammation there so long. Now we've developed some calcium deposits in the corneal layer. And in this patient, you can see it's actually obscuring their pupil. So they're going to have surgical treatment to remove these. There's really no effective therapy at that point. So just a brief bit about medications, because that's not the main focus of this talk, but first line therapies for us in general are 6 to 8 weeks of NSAIDs. And in pediatric arthritis, the preparation, frequency, and taste are extremely important. Many of our kids can only take liquid medications, and now there's very few on the market. Ibuprofen primarily, but you have to dose high dose, higher than what's on the package label, and 3 times daily. Naproxen also comes in a liquid by prescription, and we used to have meloxicam, which is no longer on the market as a suspension, but it still can be compounded at some compounding pharmacies. But trying to get little toddlers to take medication multiple times a day, especially if it's high volume, is very challenging, and the naproxen suspension is not very tasty. So we do a lot of crushed pills and early pill swallowing. We also talk about intra-articular steroid joint injections that many of you help us with, particularly if they only have 1 or 2 joints involved. That can be an excellent alternative to doing a course of NSAIDs and can kick patients, particularly oligo patients, into a long-term remission. But if they do have 3 or more joints involved at presentation, we recommend starting a DMARD or disease-modifying anti-rheumatic drug right at onset. And in pediatrics, it's mostly methotrexate. Leflunomide is another option, but requires a cholestyramine washout and is a pregnancy risk. And with our teenage population, we try to avoid that, although methotrexate is also a teratogenic medication, but can be stopped. And then obviously, if they're a systemic arthritis patient, we talked about how those patients are a little bit different. NSAIDs can still be first line if they're outpatient or mild, but many of these patients we do meet in the hospital or in ICU, and those patients really are going to require biologic therapy, particularly interleukin-1 or interleukin-6 blockade, or urgent steroids, or both. And as I talked about already, combination treatment for patients with severe presentation, so those with bony erosions, those with RF or CCP positivity, or severe polyarticular presentation with multiple contractures, we recommend that up front, or any patient that has incomplete response to other therapies. So if they've been on NSAIDs and methotrexate and failed, we're going to add a biologic. We really try hard in pediatric arthritis to avoid oral steroids because it does become a slippery slope. If you start them, it's very hard to get them off of steroids. And there's a lot of impact on their bony growth and linear growth as well, especially if they haven't hit puberty yet. And here's just a quick table. It's not the most updated. I couldn't find a great image to borrow that had everything updated on here, but these are the biologic therapies most commonly used in juvenile arthritis. There are many more that are in use for adult arthritis, but many drugs are approved in the 18 and up category before they're used in pediatrics, although we do use a lot of adult drugs off label. These are the most common. Many of them do not have FDA approval for pediatric arthritis, so they're approved for other things, and that makes it very challenging to get, such as infliximab for our patient population. But infliximab is very good at treating uveitis and severe arthritis. Some of these medications now do come in subcutaneous form for children. For example, the abatacept and the tocilizumab, as mentioned here, just says sub-Q for adults or IV only for kids, but those have both recently been approved for sub-Q for children. So overall, prognosis is very good. These kids can be treated and have normal lifestyle. We encourage other aspects of their life to remain as normal as possible. We get a lot of questions about dietary changes and activities. What can they do? What can they not do? But our goal is obviously to keep them active because movement is good for the joint and prevents joint contractures. So we really have a lot of kids that are in sports, and we encourage them trying to stay as active as possible with modifications because that's going to support their joints over time. And we also don't have any data that specific dietary changes are necessary or have any impact on childhood arthritis. We don't have any controlled studies to show that, although subjectively, certainly in adult arthritis, particularly psoriatic arthritis, there are some patients that feel better on a gluten-free diet with lower rates of joint pain. Oligoarthritis is the best overall prognosis, but unfortunately does have the higher risk of uveitis, up to a third. And certainly prognosis is multifactorial because social factors and how compliant they are with medication and office visits, what type of arthritis they have, what joints are affected, if they're major weight-bearing joints, and how early they started treatment versus a delay in care can all impact their long-term success. So in summary, arthritis is a clinical diagnosis, and you can have juvenile arthritis with completely normal labs, and imaging really supports the clinical diagnosis and is very helpful in assessment of some of the deep joints, such as hips and SI joints that we can't see swelling clinically. And here's just a picture of where I'm coming to you from in Frisco, Texas, which is a suburb in North Dallas. This is one of our new outreach hospitals at the Sports Medicine Center. And I'm sure you guys have seen this, but I had to add it just for the end. So I'm happy to take any questions that you may have at this time.
Thank you, Julie. That was wonderful, very informative. We have one question from Dr. Kulbaba, who asks if you can comment on what you use as indicators for treatment response, especially when labs can be unremarkable.
That's a great question. There's actually quite a few things that are validated in the literature. So it depends if you're asking for research purposes or what do I use on my day-to-day. But joint count is really what we look for. And by joint count, it does differ a little bit compared to adult rheumatologists because they will count number of tender joints, but that's not super accurate in children. So for us, it has to be swollen joints or it has to be tender and limited. And sometimes we don't know because joints can stay limited and kids may or may not have pain. And that's sometimes when we do use imaging to kind of help us determine if that joint is still active or if it just has chronic damage. So in our facility, I'm lucky that we have musculoskeletal ultrasound because several of my colleagues are trained, and obviously I'm right next door to radiology where we can get same-day ultrasound to take a look at the joint. But you're absolutely right. Lab work is not 100% reliable. So usually it's really exam findings and then patient reported outcomes. And there's several other validated like questionnaires that parents fill out. And there's something also called a CHAC that's like a childhood health assessment, but it kind of measures like their function at home and how they're doing. So those can be helpful tools as well, but that's a great question.
I have a practical question. You know, it's enough of a trauma to transition your kids from a pediatrician to an adult internist. And it's not really clear to me. I mean, I guess, it's not just that there's arthritis in a skeletally immature population. I mean, some of these diseases are somewhat different from the adult form, and yet not all of them go into long-term remission. So, you know, some of these kids are going to become adults with juvenile arthritis. So how is that clinically managed? And I mean, are they just handed off to adult rheumatologists? I assume you're not treating 35-year-olds. And I mean, is that in itself a peculiar subspecialty among adult rheumatologists in taking the adult people who are labeled with juvenile arthritis? You see where I'm going?
Yeah, that's a very good question. So this is obviously an area that we're very interested in and trying to work on. Transition is always an issue. It doesn't matter if it's lupus or arthritis or what the chronic condition is. I think it's challenging on both ends because you know, we want to make sure they continue to have excellent care as they transition to adult care. But you're right, the diseases aren't maybe necessarily entirely the same. I think it does open up some access to additional medications when they transition care, which can be really helpful because it's very difficult for us to get certain medications off label under 18. So sometimes I'm grateful if I have a difficult patient that, you know, turns 18. I'm curious what the adult rheumatologist, you know, thinks about some of these other medications that are newer, that are approved for 18 and up, and whether that may be a good fit for my patient. But I think there's always, you know, some discomfort on their level too, getting a very young patient that, you know, we try to do a lot of education. We try to do a lot of teaching so they understand their condition and how to take their medications and how to call for refills and how to give their own shots. But they're still on the adult rheumatology side. I think oftentimes getting some of our patients that maybe are not super savvy and have a hard time, you know, understanding their condition and care. But it's the adult world and mom's not going to be there to necessarily manage their medical condition for them. So I think it's a challenge both ways. And we're certainly, you know, trying to work. We had a fellow here in Dallas that has since graduated and moved to California, but she was very interested in transition. There was briefly a transition clinic that was set up on the adult side. She was med-peds boarded, and so she would see the kids on the pediatric side and then be the same provider and schedule them at the adult hospital. And I think that was very helpful for some of our patients for a time, but sadly that has not been picked up by another provider at this point. But I think in a world where things could be perfect, that, you know, that would be a fantastic answer if there was some sort of transition clinic. I know there's a fewer bigger institutions that have something similar to that, but it's just difficult to staff and you have a lot of patients.
So that seems like a no man's land between 16 and 18 years old, because you won't call somebody juvenile arthritis over the age of 16, and yet the medications are only on label 18 and older.
Yeah. Honestly, we see them up to 18 in our practice and sometimes 19. So they're still juvenile arthritis to us. It's just by definition, the ILAR criteria says 16 as the cutoff. So they're still pediatric to us. Sometimes it helps though with you getting medications. Oftentimes, if they're 16 and they come in with seropositive polyarthritis, I will code them as RA on the chart. That will help me. That will help me get access to drugs for them. So it's really just more of an academic distinction, but they do have care, you know, on a continuum, but around 18 is when most pediatric rheumatology practices do transition.
Well, this has been fascinating. Are there any other questions before we let Dr. Fuller go back to work? Okay. Well, thank you so much for your time.
Yeah, this is great.
Yes.
Thanks for letting me share with you guys. Y'all have a good afternoon.